Hello everyone, my name is Dr. Paul Richardson and I'm the Clinical Program Leader and Director of Clinical Research at the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston, Massachusetts. And it's my pleasure to be here at IMS and to be talking to HealthTree about the various advances that we're discussing at the meeting, that it's been my privilege to be part of actually the presentations and discuss them with colleagues at this fantastic meeting in Toronto, Canada. I wanted to touch on the so-called Duffy Null story, which we presented here again at the IMS as a poster presentation on behalf of my colleague, Dr. Lauren Mers, who unfortunately couldn't be with us, so asked me to present on her behalf. This is a very interesting story. It revolves around the Duffy Null phenotype, which occurs in certain red cells in the setting of particular populations, in particular people of equatorial African heritage and also from the Middle East. In the setting of Duffy Null, red cells are hardened against the effects of the malarial parasite Falciparum malaria. And that, of course, conveyed enormous survival advantage over the millennia for individuals who were in this area, in Africa and the Middle East. Obviously, this has conferred into the African American population up to 70% of those of African American heritage or Middle Eastern heritage have Duffy Null as their red cell phenotype. Now, what does this mean? Well, it used to be thought of primarily to be an issue of leukopenia, of so-called African leukopenia, that white cell counts would be artificially low in such patients, and this could have an impact on their benefit from chemotherapy. It's a lot more complex than that in the myeloma space. In the determination trial, where we were able to, thankfully, enroll almost 20% African American patients, we made the observation that those patients undergoing delayed transplant appeared to do extremely well if they were of African American heritage. And it wasn't that African American patients didn't benefit from transplant, they did, but those who kept it in reserve seemed to do even better. So the question then arose, why? Now, obviously, in the context of the determination trial, because we were so fortunate that our therapies were provided at no charge, socioeconomic factors were really not at play, so this was not the reason. We then dug a little deeper and started to think about pathobiology and looked at Duffy Null. And our rationale here was that Duffy Null is not just associated with this issue of low white count, which didn't seem to be a factor in this case, but it is associated with an ability to tolerate inflammation. And so we've hypothesized that perhaps the inflammatory stress of high-dose chemotherapy and stem cell transplant might in some way be at play here. And sure enough, when we looked at patients who were Duffy Null versus Duffy non-null, irrespective of how they racially identified, we found a fascinating trend that if you were Duffy Null, your hazard ratio in favor of progression-free survival benefit for keeping transplant in reserve was a striking 0.21, whereas if you went to early transplant whilst you did well, nonetheless it wasn't as beneficial as keeping it in reserve. So this has potentially enormous implications. Now, our subset analysis was all hypothesis generating, so we have to be very careful about that. But nonetheless, the observation stands. And so next steps will include further evaluation of this broadly in larger studies and larger populations to better understand how Duffy Null may not only influence the effects of treatment, but very importantly might also help us understand why is it that in, for example, patients of African American heritage, myeloma is more common. Perhaps it's got something to do with this inability to withstand the inflammatory stresses that Duffy Null confers. And this, I think, is a fascinating area of research which we're continuing to explore.